Thank you, Dr. Karen. So we're in the home straight. We now have Dr. David Caldecott and his merry band coming to entertain us for the remainder of the afternoon. First, I'd like to introduce you to the panel members, and I asked them if they could come up as I introduce them. First, there's Simon Eckermann, Senior Professor of Health Economics of the Australian Health Services Research Institute and University of Wollongong. Bill Turner, our much-loved presenter from this morning, who we've already introduced and we're very familiar with. Thank you, Bill. The Honourable Adam Searle, MLC, is the Leader of the Opposition in the New South Wales Legislative Council and has been an Australian Labor Party member of the New South Wales Legislative Council since May 2011. He was the author of the recent New South Wales Labor Medicinal Cannabis Bill, known as the Public Health Medicinal Cannabis Bill 2017. The Honourable Trevor Khan is the Nationals member of the New South Wales Legislative Council and serves as Deputy President and Chair of Committees. He has been a member of the Council since 24th March 2007. The Honourable Tammy-Ann Franks is a Greens member in the South Australian Legislative Council, where she has actively championed access to medicinal cannabis for South Australians in that Parliament. She has earlier this year had her private member's bill for legal industrial hemp production and cultivation, including medicinal cannabis research crops, passed through that Parliament, prompting the Minister for Manufacturing and Innovation to establish the South Australian Office for Industrial Hemp and Medicinal Cannabis within the Department of State Development. And Mr. Deepak Anand is the Executive Director of the Canadian National Medicinal Marijuana Association, which helped Health Canada develop their medicinal cannabis regulations, which are now famous all over the world. And Jeffrey Hergenrather, MD, is a general practitioner from the USA, specialising in cannabis, cannabinoid medicine since 1999. His medical experience includes 26 years in emergency medicine and private general practice and includes the use of cannabis since 1977. We'll organise another chair for you, sir. How's your yoga? And to chair the committee, please welcome the much beloved Dr. David Caldecott. Thank you.
Can we get a chair for our foreign visitor, please? Goodness gracious. Right. Well, look, firstly, I take offence at that. There will not be mass confusion ahead. There will be very strict conditions applied here. I'm delighted to be involved in chairing this session. I'm actually really interested in some of the answers that we're going to hear. Bit of house rules, really. The first thing, I think we'll probably do questions. The way the questions have evolved for this is that we've been given questions by many of the people in the audience and people who can't be with us. So I'm going to ask some questions off the bat. And if you've got questions, we'll sort of alternate between some from academics around the country and some from the floor. So if you have a question that you already have in your mind, that's great. Come up to the microphone and stand there and I'll flag you when I see you there. And if you don't want to ask a question, just kick back and relax. So those are the basic rules. Also, if you're going to be rude to anybody, be very aware of the fact that I will be ruder to you than you can possibly be to whoever you're going to be rude to. I'm Irish, I have sideburns, no frontal lobes, and I will crucify you. So there'll be no rudeness here, all right? Science, kindness, courage. That's what we're after. So, to start with, ladies, let's ask the locals. it's been so the foreigners can sit back and relax a bit. You go kick back. It's been an interesting trip, hasn't it, really, since we got this underway. A few years under our belts. How's it all going, and what would we have done different in hindsight? So, Tammy, do you want to crack on with that one?
I think what we could have done different in hindsight is listen to the Senate inquiry that happened that had all the evidence about a system that would work and not have changed horses in midstream after it passed the Senate and then had a completely different law passed in the lower house that wasn't consulted on, that we said from the sector and the community and the experts wasn't going to work. So we've got a system now that doesn't quite work because we chose in the lower house of the federal parliament a system that wouldn't work.
Is anything going well?
Sorry?
Is anything going well?
Oh, lots of things are going well. I think we've got massive community awareness. We've had some wonderful champions, of course, Lucy Haslam and the Haslam family in creating not only this symposium, but indeed the Tamworth one that I attended several years ago now, and the one in Sydney, and the events that we've seen in Sydney, and people brave enough to speak out about their personal experiences, people prepared to challenge the law, like Jenny Hallam from my state of South Australia. Through that, we've got a momentum now. We've got a belief from the public that this should be working, and yet we've still got those federal laws that don't quite work. But we've got the people on our side, we've got the votes on our side, and we actually have to not let the circus move on. That would be my advice. The momentum is there, the will for change is there, but if this becomes last week's issue and we let it move away from the limelight, that's where we'll really struggle.
Yeah. Thank you. Sir, next, we're walking down the line. Yep.
Well, I just think a lot of the regulation is to do with the criminal law, and that really means that the states have to act. You're right, Tammy, the people are on side, it's just that the governments are not listening. I was with Trevor on a parliamentary inquiry into this subject matter. 5 different political parties across the spectrum were represented. There were unanimous recommendations. Both government and opposition supported those recommendations, but there's been no legislative change in New South Wales since that time. There have been some administrative actions. There is some further research on clinical trials to do with medicinal cannabis, particularly with children with epilepsy, which is worthwhile, but a lot has not changed for people who need to access cannabis for medicinal reasons to avoid pain and suffering. So I think we now need to take that next step, and I think that action has to happen at a state level. I think people might have different views, but I think the fundamental problem with the federal system now in place is it relies upon a doctor's prescription. The medical profession is at least divided on whether or not to prescribe, and that's because on one view there's a lack of clinical trials, clinical research of the kind associated with pharmaceutical products. And when a doctor prescribes something, they're affirmatively saying this will help. And a lot of doctors that I've spoken to, common sense tells them that cannabis will assist. It's their belief, but they don't feel they're in a position to make a clinical affirmative prescription. And that's why the New South Wales Labor Oppositions Bill does not rely upon a prescription model. It just relies upon medical practitioner saying you have a condition. And I think that's got to be the gateway.
Yeah, it's a model that's used overseas, obviously. Simon?
Yes, I'd agree with the first speaker in that the original legislation would have certainly allowed much better optimisation of policy. And more importantly, from my field as a health economist, it would have allowed us to actually have policies to optimise net benefit of the medicinal cannabis, both growing, cultivation, and their distribution and use. And the key thing there, I think, is also that the National Academy of Science and many forms of evidence underlying that National Academy of Science have made very clear that we have the highest level of evidence in the vast majority of the populations who we want to treat, because we know from international evidence 90% of them have some form of pain as their as their condition, 70% of them as the primary condition that they want to be treated. We've got the highest level of evidence from the National Academy of Sciences, but we haven't got a process where that highest level of evidence translates into making available medicinal cannabis to those populations. So I think along the way, they've lost sight of the objective, which has to be maximising net benefit, and that's net benefit to the health system as well. So I can tell you as a health economist that if that was made available to those pain populations, we'd save about 730 million a year on pain medications, and that's the direct cost. We'd also save several $1 billion a year on the downstream better pain management that you get with medicinal cannabis relative to opioids. And if you looked at some of these statistics today, they talked about the cost of opioids being about 55 billion a year in Australia, 550 billion in the US, and certainly my calculations aren't based on those more disease-based models, burden of disease-based models, but there's many other benefits that you would have as well. So I think what has to be reintroduced is the notion of net health benefit to the health system, and indeed, as we'll talk about tomorrow, the ageing system as well, because in reality, these particular therapies give us the ability to have better and more successful ageing. We'll also talk about how they provide a great opportunity to have much better palliative care, meet the needs of palliative patients and their preferences, which are for finalising their affairs, being where they want to be, which is usually at home, and being with their friends and family. And medicinal cannabis compared to, for instance, cancer therapies, chemotherapy, radiotherapy, etc., or in conjunction with chemotherapy, radiotherapy, certainly move you along those pathways and reduce the cost to the health system. So I think it's really the refocusing on what is the objective here, which should be the net benefit to the health system, and as part of that, you absolutely should be getting access, certainly in palliative populations, in chronic pain management populations. The National Academy of Science also really points to MS spasticity populations, nausea and antiemetics in chemotherapy populations. What they also call for, which I think is really critical, is we move beyond just this simplistic thing about treatment effects to looking at the health policy impacts and to looking at the health economics. And that was the call they made in February, the National Academy of Sciences. And as far as I know, this book I've written is the only thing that does that.
Oh, no, that's it, man. No, you're done. Yeah.
Nice
It's a great book, but we're not spruiking our own albums, okay? So it's a very good book, and so we'll talk about that a little later. Mr. Khan.
Well, can I start by also observing that Adam and I were on the New South Wales inquiry. One of those who was also on the inquiry is no longer with us, Dr. John Kay. He, a bit over a year ago, died of cancer very badly. His interactions with us during those final months of his life was in part to tell us of the relief that he was receiving from the use of cannabis during that end time. And I think his work on the inquiry, even though he was great, his work on the inquiry should always be remembered. He was a source, a profound source of common sense throughout the inquiry. From my perspective, I think where we went off the rails very early on was to talk in terms of the consumer of the product as being a patient. It's a person. And I think one of the whole problems in this exercise is that the way the debate has been characterised has passed control of the decision-making from the person to the medical practitioner and to, with greatest respect to everyone here, to a bunch of public servants. And the whole thing has, to an extent, ground to a halt. By way of small anecdote, I had both my hips replaced 6 months ago. Great experience. Every day that I was in hospital, I was offered endone. From day 3, I said I didn't want it. Why? Because the side effects were I couldn't have a crap. But every day for 2 weeks, I was offered that endone 3 days, 3 times a day. And I have to say, it was a demonstration that you were actually treated as a piece of paper as you went through a system. This was not about taking drugs, it was about getting better. And I think, again, my choice, in a sense, wasn't respected throughout that whole thing. I think patients have, sorry, I'm using the word myself, people have a choice to make. If they fall within categories where they believe themselves they will achieve some benefit, I think they're entitled to a degree of self-respect.
It's great, Bill, isn't it?
Here comes Mr. Unpopular.
You're not I love you, Bill.
I'm a member of the National Party. I can be very unpopular.
So, you may not be surprised to know that I don't think we have done too much wrong in all of this. I'll address a couple of the comments. I'm not used to speaking after politicians, because I'm just a humble public servant. Take away cannabis out of that analogy about people making choices for themselves, and if the drug is, I don't know, heroin, should they be allowed to make that choice for themselves? I don't know. Some people would believe so, but that's not how we regulate medicine. If you take away the cannabis plant and you substitute the poppy plant, should people be allowed to grow that and extract what they want out of that and use it for themselves?
If you have a question, my friend, stand up and queue for it, but don't heckle, because you'll have to deal with me.
This is how we in this country deal with medicines, and cannabis hasn't made a case for itself to be treated as anything different but a medicine. And I would also say that if cannabis is able to stand on its own 2 feet, if it is good as everyone thinks it is, and I'm not expressing a personal opinion either way here, but if it is, then it can go through, it will be used, it can get to registration, and registration is the gold standard where the whole risk harm issue gets considered, both the TGA level and the PBAC level, for subsidisation through PBS. The system's there, every other medicine is subjected to that system, and cannabis should be treated the same way.
Brilliant, thank you very much. For our overseas guests, I have a scenario for you. It's a real thing, I'm not making this up. Off the south coast of Australia, as Tammy will allude to, there is an island called Kangaroo Island. It's chosen to cede from South Australia and is looking for leadership, and apparently your names are on the ballot. They're enthusiastic in the idea about introducing a medicinal cannabis program there, but they do want to hear from your expertise about the relative merits of, say, a whole plant versus a single agent approach. So if you were to pitch this one way or other, and I'm not biased, but one way or another to the citizens of Kangaroo Island, where would you go?
You bring up some good points here, and it has to do with the way we started in California was that we had a ballot initiative where the public said, we can use cannabis as medicine if approved by a physician. That seemed a reasonable gatekeeper. So what we started with then was you could grow or possess an amount of cannabis sufficient to meet your needs. And that's still the way it is in California. We don't have a defined amount of plant material, number of plants, number of square feet. We have a rule that says you can use a quantity of cannabis sufficient for your needs. We also have, in our regulations and rules, a list of approved cannabis conditions, which made sense. It was just kind of priming the pump, but it's concluded with any other condition for which cannabis provides relief. So now we're facing this new era, now 21 years down the line, where we're saying, okay, now anybody, a property owner, can grow 6 plants of cannabis in their yard for their own purposes without any regulation, without any physician approval. So the combination of these two is really saying, okay, anybody should be able to grow the plant for any condition for which you believe it's necessary and for a quantity sufficient for your needs. Now, that makes sense to us in California. The other side of the coin is if I'm sending a patient out and I'm saying, okay, I want you to look for this kind of a strain, or look for this ratio of cannabinoids, or look for this concentration. And if I don't want to have anybody fall through the cracks, because I've got 1-year-old babies with tuberous sclerosis and patients with seizure disorders and autistic kids, and throughout the childhood there are many different conditions that respond very well. Then I've got the adults and the chronic pain and the mood disorders and the inflammatory bowel diseases and the migraine headaches and the seizure disorders and the autoimmune diseases, and the list is long. You've been hearing about that list. But if I want them to find a specific medicine that I believe might be best, I want them to be able to go and access that medicine from a source where I am confident that they can get what they're looking for. So now we're talking about maybe not a single molecule, but at least a measured medicine of quality, so that I know that the product that they're going to get is organically grown, and that there are no solvents or residual chemicals that might be in here from processing the cannabis, and that they can get a measured amount of medicine in a dose that would make me comfortable in advising them, okay, go home and take a dropper full of this medicine 3 times a day, or whatever the recommendation might be. So now we need a dispensary and the government's involvement. Really, the way we ought to have it in the United States is that the federal government, by way of our Constitution and really our federal agencies, should not be regulating plants. It just doesn't make sense that they're regulating plants. These were given to us. They're for us to be able to utilize. But when it comes to making medicine, we're dealing with something else, and we need the government's involvement and responsibility in providing safe medicine to the public. Now we have something quite different. It's clear that in measured medicine, if we are isolating chemicals, we don't have as good a medicine when it comes to cannabis medicines. It just isn't that way, whether we're dealing with the synergy of cannabinoids that are able to kill cancer cells better, or if we're dealing with the entourage effect and providing all of these other not only the cannabinoids, but these terpenoid molecules, we have better medicine when we're dealing with the whole plant extracts.
Yep. Thank you. And Your Excellency, the envoy from Canada, here on the business of the debonair and attractive Mr. Trudeau, how would your government take over Kangaroo Island?
So much like California, we've had the benefit of, or actually a misfortune of going through the court systems. Our access has been sort of done with the government kicking and screaming, being ordered by first the lower court and then by the Supreme Court to actually provide access. And that's how our regulations came about. So it's quite patient-centric. We've got 70,000 physicians in Canada, 7,500 physicians are currently prescribing medical cannabis. And the advice that I would have is twofold. One, for physicians, there's a lot of great information out in Canada and the Netherlands in terms of evidence-based information as to how you can prescribe cannabis. So definitely reach out to us and learn from some of that experience. I know OSCAN is doing some work with Dr. Schechter in Canada. We've got several other physicians that I'm more than happy to recommend you connect with and get a real understanding in terms of how this is being prescribed. We've got the ICRS, which is the International Cannabis Research Society, that's doing some awesome work in terms of understanding clinical trials around the world, benefits that come therein. We've got the CCIC, which is the Canadian Centre for Investigation of Cannabinoids, that's also doing similar work. So there's some real good body of information there that I would encourage physicians to reach out to. In terms of patients, you've been quite lucky. You haven't had to go through the Supreme Court. You've got a government that's actually developed a program, albeit not the best program, Our program had shortcomings. It certainly currently has shortcomings. But work with the bureaucrats versus trying to get against them, because it's only going to be to your benefit. You need to align that vision along with physicians to be able to get benefit out of this. And that's sort of been our experience so far.
Thank you very much indeed. Bill, are we going to have a trade blockade there? Are you going to invade? Is there anything there that appalls you, or is it just a different way of thinking?
They just, well, I mean, I'd ask Dr. Hergenrather. He said government shouldn't be regulating the plant. Okay, again, I'll throw in the poppies. Should governments regulate poppies? I believe they should, because of the dangers of the opioids that come from them. I'm not saying that cannabis is anywhere near as dangerous as opioids, don't get me wrong, okay? All I'm saying is that there are reasons we're regulating these things. As far as Kangaroo Island being set up, succeeding from this, if they sign the single convention, we'll deal with them.
Good, excellent to know. So, our political friends, this is something that the horse is bolted now in public opinion. You're not going back from this either in Australia or globally. I think the current percentages is 91% of the Australian population supports a regime. I think that was of March last year. From a political perspective, why is it so scary? You have to look under rocks and stones to find politicians who are prepared to stand up to this. And then they change their minds halfway through, obviously with some advice from the TGA. But why is it difficult for politicians at both federal and state levels to get stuck into this debate and represent, well, for want of a better word, the will of the people? Tammy.
Well, it's actually easier for me than most politicians. So I'm going to say my leader from the Greens Party at a federal level is Dr. Richard Di Natale, who's taken some great leadership on this. I'm given a lot of cover by that. I also have party policy that supports me to talk about this issue in the first place. Many other people from many other different political parties don't either have that internal support and that leadership support, and certainly not the policy support that I have. So I actually think it's less courageous for me to talk about this, and it has been for a long time, than it has been for people from Labor, Liberal and National Party and Conservatives. What I would say is that when you do talk about this, you get every single myth, reefer madness on every single time. So you go on radio and it descends into a farce of people making stoner jokes or thinking that you've got another agenda, and it still descends to that level. Even with education, even with all of the information that we have and the experts advising us. But we've also got a lack of leadership coming from the medical community, because they're not armed with the resources, they haven't been given the training. The opinion leaders, they balk at the first step, because you get an avalanche of ill-informed or indeed quite destructive and other agendas thrown at you if you stick your head up on this. So for those politicians who have stuck their head up on this, I think you should be applauding them and thanking them, but also supporting them to keep going, because it is a much tougher slog than I even thought it would be, because we thought we'd gotten there and we really haven't yet. And yet it actually has lost that flavour of the month interest. So having the stamina to keep going and to keep showing up and to keep having things like this happen, that's what's actually going to keep giving those people with the courage, that have shown the courage to keep going. And I just want to make a slight comment. The other, Kangaroo Island seceding, at first I thought you were serious. And I'm sure that if Kangaroo Island did secede, the family that lives just across the water from Kangaroo Island, Victor Harbour, the Fulton family, who were much celebrated in my state and much known in my state, and indeed much vilified in my state. It's a family with 2 little girls, degenerative lung condition. They packed up and went to Canada. Oh, and you know of the Fulton family?
Yes, absolutely.
Yes, and they're well known in Canada as the Aussie medical refugees.
We call them cannabis refugees.
Cannabis refugees. I call them cannabis refugees as well. They fled to Canada, they got licenses, they came back to South Australia. The girls, their health improved dramatically. And then what they had was the medical profession come down on them like a ton of bricks, and the child protection authorities in my state come down on them like a ton of bricks. And what they did, they then became refugees again and had to flee to Queensland because child protection was going to take those two girls off them, or indeed were basically put a range of conditions that said they were endangering the health of those girls. And that was bureaucrats, I think, acting well beyond their scope. And what they did, they went to Queensland and they got a letter there from, an assessment there from the child protection authorities in Queensland that says they're not harming their children. Indeed, they are good parents. So they've been able to move back to Victor Harbour. I'm sure they'd love to move to Kangaroo Island.
Oh, it's going to be beautiful.
Sorry, I just had to
Tammy.
share
It's
that
gonna be
story because I
beautiful.
thought they would love it if Kangaroo Island was seceded.
Adam, just as an additional question there, in the sort of backrooms and toilets of federal and state parliaments, behind the public facade, is there general agreement between the parties that, Jesus, I can't say this, but quietly I agree with you? Is that something that you would suggest?
I wouldn't characterise it like that. I mean, I think most politicians agree that there is a need for change. In the New South Wales Labor Party, there's no problem standing up on this issue. It was my leader, Luke Foley, who actually moved that we have the inquiry. It's been our official party policy in New South Wales to legalise and provide access for medicinal cannabis, and we have a bill in the Parliament that we will vote for. So we don't need any persuading. I think one of the difficulties is...
What about your federal offsiders?
I can't speak for them.
Good, I like it, nice answer.
And
Yeah.
I wouldn't want to try and speak for them. And no doubt there are other issues to do with the single convention that might be at play for them that don't weigh very heavily on my mind. But it seems to me that the fundamental problem rests not so much with the politicians but with the bureaucracy, and that's not to pass the buck. But in my observations as a public servant, as a ministerial staffer, and now as a member of Parliament, very few politicians are subject matter experts in much, but ministers are not necessarily specifically trained for the portfolios they've got.
I think you're right, yes.
And when they're faced with a challenge, and this is a challenge, they go to their public servants and they say, what should I do? And in this case, the health bureaucrats go, well, there's no clinical trials here in New South Wales. We don't have double-blind randomised trials. We don't have all of this sort of information for you, Minister, that we think is necessary before you can change anything. And so it's therefore very easy for governments to go, well, the evidence isn't in. Now, to take Simon's point, if you look at it in a slightly different way, the evidence is clear and overwhelming. It's just not here in Australia. The information we have is lived experience. My father died of cancer in 2004. I saw firsthand the relief he got from medicinal cannabis. So I've lived that, but not everybody has. And so I think politicians, governments need to say, well, look, there is evidence. We understand what the bureaucrats are saying, but we have to make a policy decision. If we make the decision that we want medicinal cannabis to be a lived reality, that we want it to actually be available, not like the federal system, with all due respect, the fictional availability, where you have a construct, where the politicians go, oh, it's actually all the doctor's fault, where we actually want people who are suffering to have meaningful access. The politicians have to make the policy decision to say, we will do this. And then the bureaucrats will fall into line. They will help you facilitate it. But you've got to make the policy decision, and that just hasn't happened, in my view, at either a state or a federal level.
Thank you. Mr. Khan, are you guys being honest and forward-facing in this policy? Are you representing, or are you just hedging your bets?
Look, on the right of politics, it's more complicated. I think there's a variety of views across the party rooms. and I can only speak in terms of at the state level. I think at a federal level, who knows? But at a state level, there is a wide spectrum of views on this subject. Some vehemently against, obviously. Some in favour. In terms of turning that variety of views into legislative action is more difficult. Unfortunately, as in most areas, these things become politicised. You know, we talked in terms of the inquiry. When people went on to that inquiry from the far right through to the far left, there were those potted views. I didn't, for a variety of reasons, want to be there, but there was those potted views on it, and it took at least the first day of serious evidence to get to a point where everyone said, well, what the hell are we arguing about? Now, it only took a day of evidence, and it took, in part, evidence from the Department of Health to demonstrate why the position that was adopted was so foolish. You know, being told that it would cause sterility to people who are terminally ill, being told that it could cause lung cancer to people who got cancer. It just, actually, their evidence was quite compelling in producing the reverse result from what they anticipated. But the problem is, it's still in a political environment. We see it in a variety of things, that we can agree on a whole variety of things. You know, we will deal with an issue of, dare I say, safe access zones around abortion clinics shortly in New South Wales, and that's a really difficult thing, and if it's done in a way where it's introduced by one party, it will fail. So we have to work out a way, and I think the one thing we've learned in New South Wales is you actually can achieve some quite interesting reform if you can find mechanisms to get away from the straight party political structure. So unlike Adam, who says, I think it's partly the fault of foolish ministers and malevolent bureaucrats. Yes, there's that element, but it's also we get so tribal that we lose capacity for independent thought. So you've just got to work a way. I have to say it's not entirely damaging to have a different view on either side of politics. You know, the person who chaired our inquiry is now a minister. She certainly wasn't damaged by the experience, and she did a bloody good job, and I think that was recognised. So it just takes us to be able to get out of our silos, have a chat, work out a way of getting around sometimes our ministers and our bureaucrats, and we can do it. And look, I think this is one of those areas where, at least in our state, I think we're capable of doing it.
Thank you. And Bill, just to clarify something, maybe just a little tongue-in-cheek, I suppose, but you're an employee of the politicians and more or less just do as they say, isn't that right?
Well, it's not that simple, but yes. I mean, I think, was it Adam said that, you know, if the politicians tell us to do something, we'll fall into line and do it. That's the art of a great public servant. Yeah. Our role is to give frank and fearless advice, and if a minister came to me and said, you know, let's do the Coloradan system, my advice would be, don't do that, Minister. There are a whole heap of problems with that, and list them out. But if the minister then said, no, I'm going to do it, then that would be my job then.
You find a way.
Yeah. Just an interesting point about that last question, though. If you read Hansard from the 23rd and 24th of February 2016, you'll find politician after politician on all sides of the spectrum falling over themselves to endorse the policy that we put in place. I don't think there's a problem at the political level per se. I think that at that point in time, the Greens, Labor, the crossbenchers and the government all said this was the best policy, and that's what we did.
Thank you so much for your patience standing there. Use your calves, don't get DVTs. I think you were standing first, sir. Tell us your question, please. Who's it directed to? Introduce yourself and say who your question is for, please.
My name is Michael Stoopman. It's addressed to, of course, Mr. Bill Turner. Thank you. My question actually goes back to your original form of studies, and it's out of the box altogether. Considering that mammals also have an endocannabinoid system, is it possible that we can actually prescribe this medication to our pets, to dogs and cats and horses, etc., without any objection from the TGA or anybody else?
So it actually highlights some of the issues that I get concerned about in this space. At this point in time, the legislation doesn't provide for that. It's health legislation, and everything that we produce within our system or import is for use by humans only. It's up to the Department of Agriculture and their counterparts in states and territories and the Australian Veterinary Medicines, Australian Pesticides and Veterinary Medicines Authority to determine the policy for use in animals. What I would say is I'm very, very concerned as a veterinarian about people dabbling in this with their pets. I have a good friend of mine I graduated university with is a toxicologist, and she informs me that there are recorded deaths in cattle from cannabis and in dogs, and I would have a very...
Was that from smoked or orally ingested?
Ingested. And I'd have very grave concerns about anybody who gave it to cats. I can't find anything in the literature about it, but cats are a unique situation in that their livers haven't developed the metabolism pathways that other animals have. It's because their obligate carnivore lifestyle doesn't expose them to plant material and through their course of their evolution. And so they're susceptible to toxicities of all sorts. Aspirin will kill a cat, and that's the reason why. So I'd be very concerned about people doing this without professional oversight.
Mm-hmm. Seems like an excellent use for cats. We'll take another from the floor. Ma'am.
Hi, my name's Laura. I'm from Canberra. My question goes out to our politicians and Bill. Sorry. I just have found it really hard to get a straight answer why it's taking so long for people suffering chronic illness to qualify under any legislation that is kind of coming or has been passed, despite it affecting 1 in 4 or 1 in 5 Australians. It affects more people than intractable epilepsy or, people with palliative cancer.
I can start with that if you like. Under Commonwealth legislation, there is no restriction, and people with chronic illness can qualify if their doctor applies and have received medicinal cannabis. I know it's not in great numbers, but I'll go back to what I said this morning. If we've had 10,000 applications, there's probably 10,000 people that would have got it. If we've only had 188, and so ultimately there's only a handful of people that have received it. It's not a barrier from the Commonwealth level. The only legislation in the country that specifically names a condition is the Victorian legislation. However, as Margot pointed out today, there's Schedule 8 legislation, which works in tandem with the Medicinal Cannabis Act. You can provide for chronic illness through that pathway. So again, I'll go back to what I've said previously. The doctors aren't coming forward to prescribe this.
So, sorry, can I just ask a quick follow-up question on that?
Go on then.
My rheumatologist compared me using medicinal cannabis to treating my pain with heroin. So I've got a very uneducated doctor. None of my doctors really do support, in terms of cannabis, I shouldn't say uneducated, he did go to uni for a long time. But in terms of cannabis, so unwilling to support it. So for me, I don't understand how I can apply if those doctors aren't willing.
Again, at the end of the day, doctors make treatment decisions in consultation with their patients. The system that we've put in place puts the doctor central to those decisions with some oversight because of the great unknowns about cannabis. I know lots of people think there's lots of things that is known, but it's not collated. And we're not just drawing on Australian information, we're drawing on information globally. As I said during my presentation, lots of doctors don't know a lot about this, And it is unethical and inappropriate for a doctor to be prescribing something they don't know a lot about and don't know what the outcomes might be. That's not in patients' interest. So the only thing I can advise to you is seek second opinion, which is always your right.
Can I just make a...
Sorry, you did ask for the politicians to answer this, and I'd like to say the politicians are hearing from lots of doctors who can't work their way through the system, and it's unethical and inappropriate that they didn't get the appropriate rollout of training. They didn't learn about this at university. Now, a doctor in SA can prescribe you cocaine, quite legally. It doesn't happen, but they can't, and they don't, have the support and the training to prescribe medical cannabis to a South Australian patient at the moment because they've never been given it. It's unethical and inappropriate that that training has not been rolled out and championed by the health departments.
Well, I go back to what I said earlier. I think the prescription model is a mistake in this situation. And I think whether it's a question of doctor training or a willingness of doctors to look at other evidence other than just whether there are clinical trials here in Australia. But the reason why things haven't yet changed in New South Wales, very simply, is that the Parliament has not acted.
Yep.
Now there is a bill before the Parliament, at the risk of selling my own album.
No,
Dr.
you are.
Caldicott.
You are.
I understand. But even if this initiative doesn't succeed, what it is doing is making sure that the conversation continues. And Trevor's right. There is a view across parties that law needs to change if we are to make this a reality. And I think it will happen in New South Wales. The public are overwhelmingly in favour. Not all politicians are listening, but I think enough are, and I think things will change in the near future.
Thank you.
And Mr. Khan?
No, I don't need to add. I'll second what Adam says.
Go hard, man. As long as you're not spruiking your book, you're fine.
Yes, absolutely. No, it wasn't about spruiking the book.
Go ahead.
The only analysis out there. I'd just like to comment on both. I mean, both those perspectives I absolutely support. The key thing here, I think, is we've got a situation where we need combined research, reimbursement, and regulatory approaches. And we've created this system where we get a barrier to the type of research we actually want, which is for plant-based whole spectrum things. We tend to be going for pharmaceutical single-agent therapies. We know that people out there in the community who have medicinal cannabis much prefer the plant-based because they get the entourage effects of the terpenes, CBDs, and the THC. We also know that those plant-based varieties cost a lot less to grow, and we have the potential to have good agricultural practice, good manufacturing practice, as they do in Israel, as Bedrocan does in Europe. So to me, the real key is, if you want to optimise, and this session's meant to be optimising medicinal cannabis policy, you need to be growing those CBD, terpene and THC-rich varieties for research and for provision in practice. And the clear way to do that, which was very well expounded this morning by David Vassar, is doing N-of-1 trials. It's 21st century medicine, it's precision medicine, you're optimising to the individual needs of the patient. And to get that, we need to be growing in Australia these varieties, because we're not going to get it from the imports. The imports are still going to be single-agent therapies, or with things like Sativex still wrapped up and charged $16,000 a year. We can produce it in Australia for, certainly with outdoor growing, about $1 a gram as a distributed cost, which is $365 a year. And it's going to be higher quality. It's going to also, if it's grown outdoors, not have all the energy use considerations that you have if you grow it indoors, which are huge. And they've experienced that in the United States, where each pound produced is the equivalent of a car driving across America 7 times. And we know that the 1 million people in the States, it's more than 5 million cars equivalent in growing the things indoors. We have the ideal conditions in Australia.
You'd think that the Nationals would be all over this. It'd been the sort of never mind the health and but from an agricultural and primary industry perspective, farmers are doing it tough in this country. This is potentially a boon for that industry, where you're so powerful politically.
Oh, I'm pleased you say that.
Yeah, I think the National Party is very strong in the country.
I think at least in the New South Wales context, it actually arose out of the inquiry. A few of us went down to Tasmania. Amongst other things, as a sidelight, we went and looked at the poppy industry, and we're now growing poppies in New South Wales, partly as a result of that very
Producing
trip.
40% of the world's morphine there.
Well,
Doing it very well.
hopefully we'll get a percentage of that in due course. But yes, look, there is that. But I don't think these things are made on that basis. But I just wanted to go back to a comment about, in a sense, having a poke at the doctors. I think it's a big ask in terms of what you're asking doctors to do. It's not just about asking doctors to look at cannabis. You're actually asking them to change in a way their mindset about how they do a variety of things. And it's why we've seen difficulty with dealing with the medical profession in a whole series of things. They're used to, in a sense, pulling out their pad and going to a particular drug that they're well accustomed to, and then prescribing that drug. And they convince themselves that, look, you can particularly identify the amount that patient will need, and if you give them that on a daily basis or on a 6-hourly or 4-hourly basis, then it will produce a particular result. Quite frankly, half of that is a myth. We saw that in terms of the chemotherapy dosing inquiry that we've had in New South Wales, and the huge variety of dosages that are given to cancer patients. But putting all that aside, once you go to cannabis, particularly cannabis in raw form, then you're asking the doctor to embark upon a whole different exercise. And I think it's asking a lot for the doctor to take responsibility for it. That's why, at least at the start, the compassionate access schemes, I think, are the answer. And I know that's Adam's bill, which, if it comes to my house, who knows how I'll have to vote. But those compassionate access schemes, where essentially what you're asking the medical practitioner to do is to identify the illness or condition, but not be involved in the prescribing of the dosage, allows the medical practitioner to be involved in a conversation with the patient about the use of the product, the possible contraindications, the interaction with other drugs and the like, and not yet have to take the full responsibility for the outcomes of the use of that product.
And that's a fairly common global model.
Well, and that's absolutely right. And when you look at it, there's a whole variety of other circumstances where persons take products which are not prescription, whether it's fibre to get over their constipation in terms of, instead of taking all the drugs they give you in hospital, or whether it's alcohol, or whether it's cigarettes. Those are the sort of conversations that doctors are capable of having every day with their patients, working out how they interact. Now, the bottom line is one of the major bad drugs that we have in our society is alcohol. It leads to higher levels of deaths in a whole variety of things than anything that we're talking about with cannabis. Like, we're struggling to find somebody who's died with cannabis. You walk outside and read the paper and you'll see how many people have died from alcohol. And yet we don't put it through this same thing. So if you put in place a proper compassionate access scheme, we can move forward.
David, just on that, it is a big ask for doctors, because while cannabis is regulated by criminal law, and notwithstanding the federal scheme, it's a real live issue as to whether or not their professional and legal obligations are properly engaged, and their professional indemnity insurance is engaged, if they are then to actually actively prescribe something that is regulated by criminal law. I agree with Trevor. I don't think it's not a criticism of the medical profession. They might evolve better with more training, but it's a whole lot of other legal and regulatory changes needed if we'd expect them to play a different role, which is why it shouldn't be dependent upon a prescription basis.
Dr. Hergenrather, this was directed to the politicians, but now that you're the president of Kangaroo Island, you're allowed to answer the question.
All right. Well, here at Kangaroo Island, we have a situation where the medical college does not have any advocate for the plant. And so the way it's working is every minute of a medical student's education is decided far in advance. And the way it works is that the drug companies vie for minutes of education, and is divided up to where they know that their product is going to be covered in terms of basic physiology and pharmacology, so that the doc is introduced to those drugs and comes out of the medical training well aware of how that drug can be used in order to enact a response. But cannabis does not have an advocate in medical training. And it's going to take, on Kangaroo Island and a lot of other places, a concerted effort to bring cannabinoid education, cannabis education, herbal education into the view of the physicians, because it won't happen otherwise. And we're still facing this same problem in the United States, where most doctors have no familiarity with this. There is a fringe group of, the 0 something percent of doctors who say, there might be something here, I'd like to learn about it, and they go out of their way to understand it and recommend it, or approve it for use in those states that are allowing it. But for the vast majority of doctors, it's just a scary consideration to enter into recommending cannabis to anybody if they really have had no training about it at all. So,
Your Excellency,
please.
So just to add to that, so there's, that's great actually. So we've got 7,500 physicians actually prescribing medical cannabis, over 200,000 patients in Canada that have used medical cannabis, that currently use medical cannabis without incident. Our physicians are learning as they go. We've got tremendous research bodies. I invite everybody, including the politicians, to come out and look at our model. Nobody's died yet.
In a previous iteration, sir, you have in fact designed education, if I'm not mistaken.
Correct, yes. I've written a program to design education on that. And I just want to say we're quite proud to be the first G7 nation to be able to legalize cannabis for recreational purposes, July 1st, 2018.
Your diplomatic status has been revoked, sir. And thank you again. Yes, from the floor, please.
I have a question, but it's
Who are you and who's it for?
Tony Fitzgerald. I have a question. It's going to be at the end, but I just want to tell you my story. I'm a cancer patient right now. 5 years beating cancer. I've got cancer now. 2 months ago, I was told by my doctor, there's nothing more we can do, no more radio, no more chemo, no more surgery, go away and die within the next 18 months. I'll try and make this succinct as possible. My cancer started in 2012. It was a HPV-16 related virus in my tonsil, primary, spread to my lymph nodes. I had radiation, chemotherapy. The chemotherapy, it's a Taximab, and I got very, very ill. Then I went through that journey in suffering and in pain, but they gave me, all the standard opiums and whatever. I was on morphine. Bring it forward to 2015, I got cancer again. And it came up with a nasopharynx tumour here, pushed up a C1, wrapped around my carotid artery. I had radiation for 7 weeks. Then I had pain relief through opiums, right? And then again in August in 2015, I got the cancer back again, down in the neck area. So they did a full neck discectomy. That's why I'm talking a bit strange. But a full neck discectomy, 14 hours on the table, pain relief, opiums again, morphine, you name it. So bring me up to this year, 2017, believe it or not, January 2017, I got the cancer again. And it's in 6 places. The lower base of my tongue, which means that my tongue's affected, lymph nodes, around the thyroid, in the chest here and underneath the armpit. So my doctors say to me, I go to my doctors at the Prince of Wales Hospital and say, right, you're telling me I'm going to die within 18 months. What can I do? As of 4 weeks ago, they said, the only thing we can do is immunotherapy. It's $3,000 a week, $3,000 for the program, which goes for 3 weeks. You've got to do it for a whole year, so you work that out, it's about $200,000. That's the only thing that we can suggest. What do you think? It's going to come out of your back pocket, $200,000. I'm going, that's not going to happen. The clinical trials are not even proven. So in my mind, I'm saying, where next, where next, where next, where next? So then I happened to stumble across the video of Dan about his story. And then I saw them go to Israel and Dr. Raphael, who I've been in contact with, and we got emails going back and forward. I said at 11:45 at night, within 8 hours he replied to me. I outlined all my condition, HPV 16. I call it's oral sex, by the way, if you don't know, and I say this bluntly because I want to get the message out there because I'm going to be a vehicle for the message. I got it from licking pussy. That's it. That's how I get people's attention. And when I say that, people look at me and go, what? And then I tell them the story about HPV cancer. And that's what my mission is, to make awareness about HPV 16. Okay. So to just close up, I'm desperate. I'm looking around for an alternative. There is nothing here in Australia for me. I know that. So then I see Dr. Raphael, send him an email, he comes back to me, and he says words to the tone of the effect, I won't get specific. But I asked him a question. I said, knowing about cannabis, CB1 and 2, my theory and thinking is that one, I can take the one for the palliative pain, because my neck, it's like a boa constrictor around my neck 24/7. So I thought that's good. CB2, this might be able to kill cancer.
I might get you to
wrap it up?
Just not stop immediately, but
Yep.
just wrap up a little.
Yep.
I think there's a lot of really valuable narrative here from
Yeah.
people in the audience, but I want to ensure that we get our maximum benefit from
The question's going to go to them.
Yeah, so if there's a question,
Yep.
that's smashing.
Well,
Otherwise,
I'm at a point now where, look, I've gone to after finding out that I can get access to cannabis, and Dr. Raphael says this, and he mentioned, CBD and THC. So I've gone to my doctor and said, what do you think? Oh, can't touch it. Right. Then I've gone to my radiologist, and he said, oh, we've had a person that's on it now, and their tumour's reduced. CBD. I said, well, how can I get access to it? I don't know. So I'm at a point now where I've got to make a decision to do something. And now the only alternatives I've got is to do hyperbaric chamber or stuff over in Germany, wherever, vitamin C injection, oxygen therapy, whatever, but that costs a lot of money. I'm looking for, with my conditions here in Australia, where I can get access to two things. One, pain relief. Two, is to take something that might cure my cancer or best put it at bay.
thank you.
So where to next?
I don't think anyone on the panel has the answer to that question, but I
Yeah.
think it's a question that many in the audience have on the back of their minds.
Yeah.
So thank you very much for sharing that with us.
Yeah, I'm not agitated about it. I'm quite empowered about it. This is why I'm here. I'm a life coach. I brought life coaching to Australia in 1998, and I want to empower people to basically make sure they get access to cannabis that may fix their ailment.
Thank you again for that. What we might do is limit most of this to sort of questions, if that's all right. I think we've got an abundance of time during the course of the weekend for people to tell their story. I think it's really important that particularly our elected representatives hear these stories, because it's in fact going to be the narrative that changes things rather than dumbass Irish people like myself. I've got a very quick one for you, sir, and we'll come to you after that. And no, I'm not going to grass up the questioner. It's not me. But so in projections to the International Narcotics Control Board, the Australian estimates, which have been submitted for 2017, is, I think, and maybe we're wrong, maybe we've got a decimal point out. Is it 50,000 grams? Is that about right?
What's 50,000 grams?
50 kilos.
50 kilos. That may be close to what it is.
Yeah,
I don't know. I mean, just so you're aware, though, the estimates are estimates only.
Yeah.
And we can raise those.
Can you double them?
Well,
Could you
if
raise them by a
necessary-
factor?
If
in order?
necessary,
Yeah, no.
absolutely. The issue will become if we do that and we say 100 kilos or a tonne or 8 tonnes, and then we're using 3 grams. The INCB is going to get a be suspicious about us.
There's going to be a whole bunch of dead
we
cats
try to
around
make
Australia, aren't there?
We try to make them as realistic as possible.
Yeah.
And they control the global production, import, export. And then if we look like we're getting to that limit, we go, hang on, we need more.
Top up.
Tell them, we top it up.
Yeah, okay. Because, of course, that quantity, and once again, I have to bow to my mathematical health economist friend, but by my calculations, using the World Health Organization definition of what, say, for example, one joint would be, That's enough to service the needs of 136 patients.
No, I couldn't comment on that.
So
that's based on our best guesses at the time.
Yeah.
I mean, as I said,
Was that based on your expectation of how many patients there would be, or?
No, that's based on our. So when we come to estimates, we talk to the prospective suppliers.
Okay.
Right?
When you say suppliers, is that the people supplying the
importing
marijuana?
it, or people who are going to be growing it at some point. So let me go to the way that the opioids work.
Yeah.
Every year we have a meeting with the industry. We talk with them collectively and one-on-one. We look at what they did last year. We look at what they're projecting for the following year.
The overseas industry, or?
No, our local industry.
Local cannabis industry.
Yeah.
Okay.
No, not cannabis industry. This is for opioids.
Okay, opioids, yeah.
Right? So this is what we've been doing for 40 years with opioids. We look at what they did last year, they tell us what they think they're going to be doing next year, and then we make an estimate based on those sorts of figures. For example, if a company says we did 1,000, we planted 1,000 hectares last year, but we want 10,000 hectares this year, we might get a little suspicious about that growth rate.
So this is pretty well established for the opiate industry. So where did that advice come from for this particular value for cannabis?
I don't know the derivation of the figure at the time. It would have been set probably back in June last year.
Is it the ODC who sets that, or the TGA?
The ODC
Okay.
does it, but my team does that. I don't get
We'll let you
involved
take
in
that on notice, and
Yep.
maybe you can come back to us with the answers,
I
how
could
that figure
possibly
was
do
derived.
that.
Is that all right?
Yep.
Lovely. You, sir.
Sorry,
you're
can
the
I
most
just can I just quickly add to that? So we've got a lot of data. In fact, it's 2.5 grams that each patient in Canada is using. There's 200,000 kilos that are
Per day.
grown. Per
day
day,
per
exactly.
patient, yep.
And so we've got a lot of data. Health Canada actually publishes this information on their website in terms of how much is being prescribed, what the different disease states are. So, I mean, the data's out there.
Yeah.
You need to take the guessing out of it and really reach
There's
out
not
to
a
us.
lot I need to guess, is there?
David,
Yeah,
just to let you know, if they did 2.5 grams a day, well, that would be 55 patients.
Oh, my sweet baby Jesus. Listen to the maths. It's just like countdown.
Your assumption is that they've got a gram a day.
Yeah, it is. That's why he's the author of the book. You're the most patient person in the room, sir. Your turn. Who are you, and who is the question for?
Hi, I'm Michael Woolridge. The question is for the whole panel. Thank you for your time, everyone. Are medicinal and recreational cannabis completely separate issues, or is the medicinal side the more pressing side of one issue?
Well, from my perspective, the medicinal side is the most pressing. There's a legitimate debate about the other, but I don't think we would want this debate to be obscured by that other issue. There's all sorts of cultural and social overlays to do with cannabis, which has historically proven to be an impediment to a sensible discussion about medicinal cannabis. I think the discussion and the priority has to be to provide meaningful relief from suffering for people who need it now. And I think discussions about recreational cannabis do a great disservice to achieving that objective in any kind of short time frame. That's my perspective.
Would it be safe to say that it is the unanimous opinion of the panel that the issues of recreational and medicinal cannabis should probably not be confounded? Any dissent to that position? You can dissent, but do you have to stand up and ask a question if you want?
Only slight. No, well, it's not just the left has a different view. Actually, the doctor who spoke much earlier on today had a different view. I think there's lots of people self-medicating. So even if you are saying one thing is recreational, another thing is medical, the medical issue is actually partially in that recreational field. And we're making people who should be treated as people and patients into criminals. So absolutely, though, I would say champion medical cannabis has to come first, because that's the reality of where we will change, and we have changed the law, and where we need to focus our efforts at the moment, because people who are sick and suffering deserve our support, and we're putting them in a position where they have to come and make speeches and advocate for absolute basic health care that they should be getting.
Mr. Khan?
Look, can I just make the observation, a whole range of areas. Actually, it doesn't matter which side of politics you're on. On the whole range of areas, one of most common arguments you get is called the slippery slope argument. So you say you make any sort of reform in this area, it will lead to the end of the world as we know it. And so in terms of that recreational area, if you in any way conflate the arguments, all you do is you arm the opponents of any sort of reform.
Thank you.
Sorry, I just wanted to add to that. So,
we're back in.
given the only country that's currently going towards legalization for recreational purposes, if you look at the stats from Colorado, Washington State, Uruguay, the war on drugs hasn't worked. We cannot arrest our way out of this problem. And, you know, I just don't understand what the big deal is. I mean, you know, for 4 years, we've had a legal medical cannabis program without incident. We've got a highly regulated environment. The government is committed to taking this out of the hands of kids. Canada has one of the largest rates of underage access to cannabis. So that's our determination, take it out of the hands of kids, take it out of the black market, and legalize it.
Thank you.
David, I would add too that I want to push the education point again, because we're not training not only doctors, we're not facing plant medicines in our school systems. You know, kids are growing up not really knowing that this plant's going to give them a terrible rash, or this plant's going to kill them, or this plant's going to make them vomit and give them a life-changing experience in taking a psychedelic. We're not facing these educational issues in our school systems whatsoever. And I think that our government could stand up a lot toward educating about the plant world. Not only there, but really our governments need also to be able to step into this area of helping the clinicians with the information that they need. For example, we should be able to look at markers of tumors and know whether or not they're going to be sensitive to cannabinoids. And this is something we put no effort into whatsoever, because it's recognizing the plant as medicine, and that is not acceptable in the United States.
Yeah, thank you. There's going to be a military excision of us out of here shortly, so we're going to just take a few more questions. The new founded state of Kangaroo Island is watching with interest the developments. They've obviously got their own systems in place, and they're working wonderfully, secretly. The ODC is very jealous, but would never say that openly. But what knowledge and information, say for example, Dr. Hergenrather and Your Excellency, what knowledge and information are you going to take back to America and to Canada as an example of how well Australia are doing things at the moment?
Well, I think what you've got right is when we started our cannabis program, we called it marijuana, and we spelt it with an H. And that's one of the most derogatory terms that you can use towards medical cannabis. And so I think what you've gotten right is you're addressing the plant by its respectable name, which is cannabis. I think that's significant. So, you know, that's my big takeaway is, you know, I think you're on the right track. You just need to look at us. I mean, the world hasn't fallen apart in Canada. It isn't going to fall apart July 1, 2018. And I invite, you know, doctors, patients, bureaucrats, politicians to come out and take a look at our framework.
So full marks for spelling, that's good, yeah. Dr. Hergenrather?
I would love to add that in Australia, I feel that there's a dialogue that we long for in the United States. We have the edifice of Health and Human Services and Public Health Service and the DEA and the FDA. These are closed doors where there is no conversation whatsoever about cannabis, really in a logical and legitimate way. And in this country, it's so refreshing to be seeing people come together and having an honest discourse about this. And I appreciate that greatly, and we'll continue to take that home to the United States.
Very nice. That's a very positive note, and we could go on for like 2 or 3 hours. I suggest we go to one of those horrible dens of hostelry where we can sort of consume alcohol together. I don't know this place, so there must be one locally, but we should probably continue this conversation. But literally about to be evicted, there are people in black glasses, and so I'm sorry that you didn't get a chance to ask your question. I want you all to join with me to thank again the panelists for what for me was an incredibly enlightening session. So let's take them away and feed them alcohol.
Always
Thank you very much, everyone, and don't forget early start in the morning for the movie A Life of Its Own. Thank you for today.